So we'll move on to the next speaker, and we have none other than a very dedicated strabismus and pediatric ophthalmologist, the president of SPOCINA, and that is none other than Yogesh Shukla ji, to tell us about current concepts in the management of intermittent exotropia.
On to karo.
No, it's on.
So, well, good afternoon, everybody. This is basically a very controversial topic also, and we have a lot of problems. It's really puzzling, you know, and the enigma of intermittent divergent strabismus. See, intermittent exotropia is common, though enigmatic means it is puzzling. Form of strabismus that presents a modest diagnostic challenge but requires considerable therapeutic challenge intensity. That was what the Eugene Helveston has written. Now, in most patients, vision is usually normal and equal. Sensory fusion is good, stereopsis is good, motor fusion is present, and versions and ductions are intact. In other words, good intermittent strabismus is very good. But when the eye deviates, central binocular cooperation is totally turned off. There is a manifest large exodeviation, large central suppression with monocular vision. The periods of this exodeviation are variable, and so are the complaints of the patient. Now, what are the really puzzling points of ITS? I'm coming directly to those points where I want to stress, you know. The accurate assessment of deviation is a really requires a lot of effort to do. Correct knowledge of the type of IDS. We know that there are so many types of IDS. Listen to the patient, the complaints of the patient, because many a times you will have to operate only on the complaints of the patient because of the cosmetic reasons. Surgical procedures, what are your choice of surgical procedures is again a problem in region. Now I'm going to show you some videos, you know, which has been really counted the real patients. I'm just giving you one example. Now this is a young girl for about 17 or 18. Now when the patient came to me, I'll tell you the complaints which she came to me. Now there's a small deviation, I mean it's basically a phoria. Now see the eye moves in. The eye moves in. Now I gave her spectacles because she had some refractive error also. And when even after giving the spectacles correction, she had a small amount of myopia. The exophoria persisted. It was more for the distance actually and less for the near. Now, this patient came to me complaints of headaches. Now the problem is that it's a small deviation, only exophoria, not tropia. Should we operate or not? Number one. Let's go to another patient. A small girl, it's about 6 or 7 years. She was seeing a lot of, mobile. And now see, when I told her to look, the left eye deviated outside. The right eye deviated. See, intermittent divergent strabismus. Very simple. But it's a small angle. It's not a large angle. It's about 25 ppd. Now, the patient came with the complaints that the small girl, because when she used to look outside in the classroom, the eye used to deviate, because now it's deviating as you saw. When I tell the little girl to see for the distance, the eye deviated. The parents were very concerned. The parents were very concerned because the children started teasing her in the school. So what should be done? Should we operate? We'll talk of that later on. Now see another boy. Another boy. He had spectacles. Already myopic, I think 3 or 4, I don't know, because a lot of, I'm just giving you one example of each. There is no tropia. There is no tropia, but when you do an alternating closure of the eyes, then the eye deviates. Still the eye deviates. Now, this was near here than exophoria, but when I told the patient to look far, there was a large exodeviation. Again, the same problem. The children in the school were teasing the boy. The parents are worried. And then it's the psychological process starts for the children. Next, another girl. I'm not giving you the videos, but this girl about 10 or 12 years old, and she had a large deviation, also alternate intermittent deviation, and only when the girl used to look at distance, then only used to identify. This is a standard, and a very common way of presentation that the eye only deviates when you look at distance. So she's a girl, about 12 or 13 years old, and the parents were very worried. Again, same problem, the psychological problems, you going to school, the problems, and the relatives start saying that, so I had to operate. The simple, as a rule, I always do intermittent divergent squint on adjustable sutures, because I don't know how the patient would fare these. So always next day when I do the adjustments, at least I am little closer to the best of the correction as possible. This I will just leave. This is a congenital esotropia. There's a different topic. I will not go into that. Now, so the take-home message is, I'm very concising it, okay? मैंने आपको जो ज़रूरी चीज़ें थी वो बता दी, because which is the main puzzling factors of this. The age of onset of exotropia should be specifically asked. 4 years with complaint should be judicially treated. Orthoptics, especially converging exercises, should be seriously employed. Intermittent exotropia should be closely watched. Vision and stereovision should be monitored. Fusion breakage with constant exotropia should be surgically. Once the fusion breaks, so we have a lot of criteria that when you should operate, when should you intervene, and when you should employ the surgical procedure. We have a lot of criteria for that, That I think you all know, so I'm not going to that. Fusion, if patient is too young, patching as per regime should be done to maintain the vision. Surgery is also indicated early if complications like DVD, HDH and other things appear. Parents' acceptance for surgery is important. You must take the consent. Of course, if the child, the parents have to be, taken into confidence and consideration. Repeat or second surgery possibility should be explained. Choice of surgical procedures should be sensibly used. Now, I still have half a minute more. Now, the problem is, what do you do in these patients? Young child, exophoria, goes into exotropia when the child looks far, because when in the school, the patient, when the child looks at the board, the eye deviates out. The other thing which is important is that why there is a problem in our establishment of evaluation. There has been a lot of work on this from Johns Hopkins also, and Dr. I forgot his name. I saw his this thing. Hunter, Dr. Hunter, David Hunter. See, he had an article I read about last year. He said that we only examine either at 3 meters or 6 meters. When they examined the exotropia for distance even further than 6 meters, there was a lot of difference. And similarly, surgical procedures, when you operate on a patient, which you have evaluated at 3 meters only, you see, the results are only 60%. And if you did your surgery after evaluation at far more distance, even further than 6 meters, they say you tell the patient to look outside into the garden or something, the results were 80%. That was what the David Hunter said. So the problem is that what we are examining, or the alternative is you at least call the patient 3 times every 2 weeks. And again examine. Every time you'll find a difference. The third alternative is you have the prism adaptation test, what we have, but it's a little costly. Fresnel prism lagana is a little costly. Har bar 15 din mein isko change karna is again a costly. But if you can put a prism and again call the patient after 2 weeks, you will find a difference of deviation. Again call the third time. Again you will find a difference. And when the last, after a month, when it has stabilized, that is your exact estimation of the deviation. Thank you very much.